Good afternoon, everyone. I welcome everyone for the Icon Amrita E-Gurukul series. Today we are having the ninth session and we'll be discussing the drugs used in sarcoma. So it's an immense pleasure to invite today's program director, Dr. Saphalta Baghmar ma'am. Ma'am has been the senior consultant and professor at Department of Medical Oncology and Hematology. And she's currently placed at Amrita Hospital. Ma'am is involved in great research activities. Ma'am, a warm welcome and hereby handing over the proceedings for you. Thank you.
Hi, welcome to all. And this is ninth session of this series. And I have been given the opportunity to introduce Abhishek Raj, and he is an Iron Man. And apart from being Iron Man, who is excelling in everything and all the malignancies. And recently, he has also started CAR T cell therapy, which is running successfully. And he's a great friend and a very learned person, and who can teach you all the malignancies. And with that, I would also take the privilege of introducing Samir Rastogi, because he is a very good friend of mine. We joined our senior residency together. We gave all the examinations together that time. And with a very short duration of time, he has achieved fame, name, and sarcomas, which is a very difficult topic, and a very few medical oncologists actually pursue that malignancy, which is a totally different world. And he has been a known figure now in sarcoma. So welcome Abhishek and welcome Samir, and I would hand over this proceeding to Abhishek now. Thank you.
Thank you. Thank you so much, Dr. Saphalta. Thank you for a very kind introduction. Thank you, Dr. Nihanty, for involving me in this Icon E-Gurukul series. It's a wonderful initiative for the students. It's such a pleasure to be here. And I think we'll be discussing about drugs in sarcoma. Dr. Saphalta has already introduced Dr. Samir Rastogi, sir. So Dr. Samir Rastogi, sir, was my association with sir goes from my MBBS days. He was my postgraduate in pediatrics when I was doing my internship. Sir has been a mentor. Sir has been a guiding force, not only during my PG preparation days, but also when I decided to take up oncology. And he needs actually no introduction. He has an internationally well recognized fame in sarcoma, and he was the one who actually prompted me to learn sarcoma, and he told us that how complex a topic sarcoma is, and he's been doing great work as far as sarcoma is concerned. So with that, I would also like to introduce Dr. Ashvin. So Dr. Ashvin is the speaker. He has kindly accepted the role to teach this drugs in sarcoma to the students. So he's an assistant professor medical oncology at CMC Vellore. So I'll welcome Dr. Ashwin on everybody's behalf. And I think Dr. Nithiya has agreed to be the examiner. So with that, I'll hand over the session to Dr. Ashwin now.
Good afternoon, everyone. I'd like to thank everyone on behalf of E-Gurukul who have given me the opportunity to share my views on this topic of drugs in sarcoma, and I hope that it will be useful for all the exam going candidates, and hope we can do justice to the topic. And can we start? Or
You can start. You can start.
if can I have my slides? Ma'am, these are the questions, ma'am. I need my...
Sophia, can you please put the main presentation one? Sophia, are you there?
Yes, ma'am. I'm just sharing, ma'am.
Yeah. So in the meantime, Samisa, you wanna have a word or anything? The students are here.
Am I audible?
Yes, sir, you're audible.
Yeah, so I'll thank this warm welcome from Dr. Abhishek and Dr. Saphalta. And I think we should start this soon so that we have a lot of things to cover.
Yes, sir.
So in case, yeah, thank you.
Uh, so, uh, so I'll start my session. So now, next, can you make it in slide? So, as we come to discuss the anyway, any of the Devita chapters, idly sarcoma. When you read the book, you would feel that it's the last topic. So most of the drugs have all been covered. So I'm just uh, talking in detail about a bit. I mean, the drugs which are not been covered as of now. So I'll be brushing through the drugs which have already been covered in the previous topics. Uh, so I'll start off with ifosfamide. So ifosfamide is, as you can see on the picture, which always comes with a package with uh, with mesna injection along with ifosfamide. Most of the packaging is in this format, and it's an alkylating agent which is almost closely similar to cyclophosphamide, and it comes in a white powder form, and it's normally the powder has to be dissolved with a sterile water, and it has to be given intravenous in a 500 ml NS. So the main concern that we are worried about ifosfamide when you're giving, because the main sarcomas that we consider for it is whether it be Ewing sarcoma or whether it be osteosarcoma or rhabdomyosarcoma, but rhabdomyosarcoma will be the drugs for rhabdomyosarcoma will be covered in the later sessions. So the main thing which I will be dealing with is Ewing sarcoma and osteosarcoma. So as we know, normally the most common that we use with Ewing sarcoma is VAC alternating dose dense 2 weekly with uh, ifosfamide and etoposide. So in that ifosfamide, the dosage would be almost like depending whether you're giving a continuous infusion or like you're giving an 1 hour injection, 1 hour infusion. So it normally is 1.8 gram per meter square day 1 to day 5 along with mesna. So it normally gets metabolized by the cytochrome P450 enzymes to its active metabolites. So the two main metabolites which I wanted to highlight were the acrolein, which causes the hemorrhagic cystitis, and the chloroacetaldehyde, which causes the encephalopathy. So, the main thing that we are worried when we give ifosfamide is we are worried about this hemorrhagic cystitis. So, how to avoid this hemorrhagic cystitis is we have to I give at least a 3 liter per meter square hydration to the patient and encourage the patient to also to drink a lot of fluids and also encourage the patient to frequently void. The patient should not keep the urine holding into the even if he has a slight bit of urge to pass urine, he has to be encouraged to go and pass, and he should be encouraged to pass urine standing in the bathroom, not lying down on the bed or in a recumbent position into a urinal, because there have been the problem is that if he doesn't void properly, the urine which remains will contain the drug and it will cause irritation of the bladder, especially the posterior wall of the bladder gets affected, especially if the patient is lying in a recumbent. So the main advice that you give is at any slightest urge of if the patient feels, he should not hold the urine. He should pass the urine even at the slightest urge to pass urine, and encourage him to take as much as water possible, and also before going to bed, if he has the urgency to pass urine, he has to clear the bladder, because if the urine gets stored in the bladder for a long time, it can predispose to causing hemorrhagic cystitis. And other thing which I wanted to highlight was the encephalopathy, which is related to ifosfamide. So the predisposing factors which lead to ifosfamide related encephalopathy would be, one is pre-existing renal failure, or if the patient is having any prior treatment, concurrent treatment with any with a cisplatin, or patient is having low albumin, or if the patient is taking any aprepitant, because it has aprepitant is also like an inhibitor of the cytochrome 450. So if it inhibits now, the level of the drug of ifosfamide goes up. So that increases the level of ifosfamide in the blood, which predisposes encephalopathy. So encephalopathy, so if you have any of these parameters, we should be cautious when we administer ifosfamide. And so ifosfamide grade related encephalopathy, there are totally 4 grades: grade 1, grade 2, grade 3, and grade 4. And that grading is called the Madvick grading of ifosfamide encephalopathy. So if you have a grade 1, which will be just fatigue or mild confusion, but a grade 4 will be life-threatening. Grade 3 would be any associated with any stupor, stator, or any seizures. And ideally, if it becomes grade 4, you're not grade 3 or grade 4, you're not supposed to rechallenge. But if it can be grade 1 or grade 2, normally this encephalopathy, which is related to ifosfamide, is a reversible. It gets reversed over 48 to 72 hours. But in case if it doesn't get reversed, then we either increase the hydration. Second, we use a drug called methylene blue, which would be 50 mg IV, which will be given over 4 to 5 minutes. Maximum 4 doses in a day, which can be considered. Next slide, please. So the mechanism of this drug, as it's an alkylating agent, like same principle like how it's with cyclophosphamide, where there will be cross-linking of strands of DNA by it binding with the nucleic acid and other intracellular structures, which results in the cell death and then finally inhibits protein and DNA synthesis. Next slide, please. So these are the various regimens which we use in sarcoma. One is the most common, which is the ifosfamide and epirubicin, which is 1.8 gram per meter square, day 1 to day 5 over 1 hour every 3 weeks, along with mesna. The other regimen is the MAID regimen, which is the mesna, the adriamycin, ifosfamide, and dacarbazine, where 2 gram per meter square continuous infusion of ifosfamide for 3 days along with mesna. And aim is without the dacarbazine, it is just adriamycin, ifosfamide, and mesna. Next slide, please. So the main side effects which are worried is one is bone marrow suppression, second is the encephalopathy and nephrotoxicity, and hemorrhagic cystitis. So the main 2 things if you have to worry is one is hemorrhagic cystitis and the encephalopathy, which I have already explained about the pathogenesis and the grading and also how to manage. And bone marrow suppression is mostly it causes most of the time patient will come to a casualty with if you do a repeat. Ideally, the first time when you give ifosfamide, it's better to sometimes we do not know how the drug's efficacy is there. Sometimes if you give day 1 to day 5, the first cycle, most of the time patients will come with like a full bone marrow suppression, and ideally it's wise to call the patient at the day 7, between day 7 to day 10. That's when the counts go down to just to have a look at the WBC count. And if you feel that the counts are low, then you can give a ideally anyway the regimens will have PEG GCSF, but still to ensure that the patient doesn't land in a refractory shock later, so that it will put that patient in your radar list to keep a close watch on that patient. Or sometimes if you feel the patient is like very is not you can maybe start with day 1 to day 3 also. If you feel the patient is like very borderline, in that case even individualize the protocol by making it day 1 to day 3. Next slide, please. Next slide. So the main thing that when you are dealing with ifosfamide is that we have to ensure that, sorry, the previous slide, ma'am. The previous slide. Yes, thank you. So the, ma'am, can you bring it to the next slide, the mesna slide, sorry. Yes, thank you. So the main thing that we have to be, we have to ensure that when you're having, most of the time, most of the companies, when they give you this drug, the ifosfamide, it gets packaged with the mesna. But sometimes, maybe if you have a vial which is without mesna, but ensure before you start the treatment with ifosfamide, you have mesna available in your ward. That is the main priority, because starting ifosfamide without MESNA is like going for suicide. So the thing MESNA, what does it stand for? It's two uh, 2 mercaptoethane sulfonate sodium. So it is basically a group. It has a free sulfahydryl group which help in forming a stable thioester bond by combining with this acrolein, which is a metabolite which gets formed by the breakdown of ifosfamide. So the daily, how do you calculate the dose? So if you are targeting, if your dosage of ifosfamide is less than 2.5 gram per meter square, then we normally give 0, 4, and 8 hours. We at least minimum the first time when you give 15 minutes before starting ifosfamide, which should be calculated by giving at least 60% of the. You split over 3 doses by taking the total dose as 60% of the total dose of ifosfamide, and then uh, we ensure that we give it at 0, 4, and 8 hours. And simultaneously, if you're giving in case if you're giving as a continuous infusion, then the first initial bolus you will be giving as 20% of the total ifosfamide dose, followed by it should be continuous infusion of mesna, which should be equal to the 40% of the total ifosfamide dose. And for example, if your ifosfamide dose exceeds more than 2.5 gram per meter square per day, then in that case, it's better to give 100% of the total ifosfamide dose. Next slide, please. So the next drug which I'm talking about is the trabectedin, which is trabectedin is one of the drug which was isolated from sea sponge. From it's an to isolate, normally in the 1960s and 70s, they in order to get they were on the exploration to get newer molecules for cancer therapy. So that time they started exploring into the sea, and then they found that there was a sea sponge by the name of E. turbinata, from which they extracted this molecule trabectedin. But apparently they had to hunt for more sea sponges to make 1 mg of trabectedin. But later on, they decided to make this in a semi-synthetic way. So trabectedin comes in a liquid form, and it is a vesicant, and it is an alkylating agent, and also it blocks the cell cycle at the G2M phase. The dosage would be 1.5 mg per meter square. It's a continuous infusion over 24 hours every 3 weeks. So normally we use this in sarcoma. Either it will be a metastatic sarcoma which has been relapsed post in the second line, or a, so in this case, normally before starting trabectedin, we have to ensure that the IV line is secure. It should be a proper IV line, preferably a central line, because any bit of drop can cause a very bad extravasation. So that's why we have to ensure that the drug is given through a central line. Next slide, please. So the side effects that you're mainly worried about is the hepatic dysfunction, then we have the fatigue, and then the bone marrow suppression, and sometimes we can have rhabdomyolysis. Next slide, please. So the next drug which I want to talk, one of the main other drug which we use is methotrexate, in the form of high dose methotrexate in cases where you have a relapsed osteosarcoma, or sometime maybe we can use it like a oral metronomic therapy in sometime inoperable desmoid tumor or recurrent desmoid tumors. So in those type of cases, we are using methotrexate. So here, what we see is that it is, as we all know, you have discussed this previously also, there are other indications maybe used in hematological malignancies, in GTN, so many, even sometimes now we are using as oral metronomic therapy, even in CS cervix. Um, so it's a cell-specific antifolate analog. And history of methotrexate is, as we all know, it was discovered by Indian biochemist by the name of Elaparagado Subagaro. But the credit went to Sidney Farber, uh, who was a hemato-oncologist at that time working in US. But he was the person who found out discovered this drug, methotrexate, who was a graduate from Madras Medical College. So where we find out that that this drug is an anti-folate analog, which acts in the S phase, which is the synthetic phase of the cell cycle. So it enters the cell through there are some carriers called reduced folate carriers. And sometimes if you take the drug orally, then you need a transporter protein, which is the folate receptor protein. So the next step that happens is that it happens polyglutamation by the enzyme polyglutamate synthesis. Basically, there will be lot of polyglutamate residue will be attached to this molecule, and that will increase the intracellular pool of the folates. Following which, it can once it gets polyglutamate, it cannot be transported out of the cell, and then it causes the inhibition of dihydrofolate reductase, which is responsible for converting the DHF, that dihydrofolate, to tetrahydrofolate into a reduced form. So because that it inhibits that step, so due to which that is more effective in the S phase, due to which the purine and synthesis, the DNA synthesis will not happen, due to which the cells die. And there is a difference between the methotrexate, the way how we use methotrexate in osteosarcoma and how we use it in ALL. In osteosarcoma, normally we give it at 12 gram per meter square over 4 hours, but whereas in ALL would be around 3 gram per meter square over 12 over 24 hours. So basically, here the main thing that we're looking is that the osteosarcoma cells are very resistant to chemotherapy. So you're trying to push a heavy dose of methotrexate through this reduced folate carrier, whereas the cells which are there, the leukemic cells, they are very sensitive to chemotherapy. So you need a very low dose, and also it's got a rapidly dividing DNA turnover. So due to which even a low dose of methotrexate will be enough. Next slide, please. So the most common question that can be asked is in Viva is that because we need leucovorin. So after 24 to 48 hours methotrexate infusion, most of the centers they'll do a methotrexate level at 0, 24, at 24, 48, and 72 hours. And then the cutoff should be like at 72 hours, you are aiming that it should be less than 0.1 micromole per liter. So the thing is, if it doesn't reach that level at 72 hours, or at 48 hours, if it is less than 10, if it's not reaching less than 10, but still more than 10, and more than 1. So basically, remember that at 24 hours, the level should be less than 10 micromoles per liter. And then at 48 hours should be less than 1 micromole per liter. And at 72 hours should be 0.1 micro per liter. If any of this criteria, at any point, if the target level of methotrexate not met, that means you have to increase the hydration, you have to increase the frequency of leucovorin administration, and then you might have to consider alternative antidotes for methotrexate toxicity. So the main thing that two drugs which we see for 5FU, the leucovorin that uses will potentiate its action. But whereas for methotrexate, we are using leucovorin for another reason. That is to rescue the normal cells from the toxicity. So where we see that the 5F, the leucovorin is what is leucovorin? Leucovorin is just the reduced tetrahydrofolate. So what it does, it will bypass that block. That is, the methotrexate will be blocking the dihydrofolate reductase. So beyond that, this tetrahydrofolate, which is actually leucovorin, which we are giving from outside. So we are bypassing that step, and then that will be used for the remaining cells, so that the cells get rescued out from the effects of methotrexate. That is the purpose of adding leucovorin for methotrexate. Whereas for adding leucovorin for 5FU is to stabilize the 5-DUMP, which actually forms a stable ternary complex with the thymidylate synthase, and along with there's a folate cofactor, which is the N4, N10 methylene folate cofactor. So they all together form one stable complex. So when we add leucovorin, it will bind to this complex, and still it will become an irreversible bond. So there will be more exposure to this. Henceforth, ideally, the job of this enzyme thymidylate synthase is to convert that 5-FDUMP into 5 DTMP to thymidine. But that step is not happened, due to which thymidine doesn't get formed. So as a result, DNA synthesis doesn't happen. So as a result, the cancer cell dies. So that is the whole principle of adding leucovorin for leucovorin for 5-FU and for methotrexate. Next slide, please. So as we know that main thing that you have to be worried when we add methotrexate is that we have to be ensuring that the patient doesn't have any underlying nephrotoxicity, or patient should be cardiology wise, patient should have a very good EF, because we are going to give a lot of hydration. So otherwise patient will end up in failure if we keep on pumping too much fluid. So you have to ensure you have a baseline echo. The LFT should be there because it can cause transaminitis and hepatic dysfunction. So as a result, liver function should be normal. And also, the other thing is nephrotoxicity, because if you have a creat clearance is bad, there will be delayed excretion of methotrexate, due to which the toxicity will go up, because you want the renal excretion of methotrexate to happen at the earliest, because the most important route for excretion of methotrexate is renal. So if your renal is not working, then the drug will stay in the system for a long time, and that can cause toxicity. And other thing which you have to be worried about is ensure that there is no third space fluid collection. Like if a patient is having pleural effusion or ascites, sometimes a patient might undergo like a craniotomy. Like for example, like a primary, initially when patient presents with headache, vomiting, upfront the neurosurgeon will do a craniotomy and remove the SOL from the brain. And because they have removed that bone, the skull, they'll remove a portion of the skull. So then there'll be fluid accumulation in the skull. Sometimes we will not pay attention to that skull fluid collection. And then we end up, that histopathology will come as primary CNS lymphoma. And then we'll have to give high dose methotrexate. Sometimes we'll be in residency, we might be missing out on that. So we have to ensure that there is no fluid collection anywhere, because what happens if you don't drain the fluid out and then start is, the problem is that the drug will accumulate in that fluid, and over a period of time it can cause delayed release of this drug from those fluid, and that then the toxicity will also go on for a longer period of time. So that's why the most important thing is to ensure that there is no third space fluid collection. Next slide, please. So these are the same side effects which I talked about. One is we have sometimes it can cause like SGS, where second is like nausea, vomiting, diarrhea, and mucositis. Then myelosuppression, transaminitis, and also sometimes you can have pneumonitis, acute kidney injury, and sometimes even neurological complications in the form of encephalopathy. Next slide, please. So the vinblastine, which is part of the vinca which are isolated from the periwinkle plant. So normally the role of vinblastine sarcoma is in cases of desmoid tumors, where we give vinblastine, and also sometime in Kaposi sarcomas we use vinblastine. And here the main thing is that we have to give it in a 50 ml NS, or you give it in a running NS over 10 minutes. The dose limiting toxicity will be myelosuppression, because it's you have to ensure that the IV line is properly secured, because if you have any extravasation, then you have to be careful, because here we have to inject locally hyaluronidase and then apply heat, so that to minimize the tissue damage. And it also, all the vinculclides, the mechanism of action is that it will inhibit the polymerization. And so there are 3 drugs. So I just want to briefly explain the main mechanism of action of the 3 groups of drug. One is taxane, vinca alkaloids, and the other one is eribulin. So in case of imagine a child is uh, like he's building, taking small blocks. Imagine these blocks to be a tubule. Like we know that the microtubules which are there in the mitotic spindle, they are made of beta tubulin, which will be in the form of alpha beta. They together form a dimer. So imagine that a child is having a building block in his hand. So when he's keep on putting one building block over the other, so this each building block will represent one dimer of this beta tubulin. So this normally this thing this process, it happens at the plus end. So you have the in the cell cycle where you have the mitotic phase. So there will be a lot of these chromosomes. They will be attached. Uh, so you'll have the microtubules. Normally, this plus and negative ends are not found at the chromosome. It only found at the microtubules which are interacting with the chromosome. So when it interacts, the negative end will be at the it will all be attached together at the centrosome, the kinetochore. The end which is at the kinetochore will be the positive end, whereas the end which is towards the side, centrosome side will be the negative end. So most of this polymerization and depolymerization will happen always at the positive end. The positive end, which is the near the kinetochore, where everything is attached, that is the microtubules which are interacting the chromosome, they get attached at that area. So that area will be having a lot of dynamic changes will be happening, because there will be uh, uh, repeated cycles of polymerization, depolymerization. So there's a repeat growing, shrinking, because that's what is happening. So that is called something like dynamic instability that is normally required. So now coming to what is happening is that you imagine that there's a building block, that is the child is putting one block over the other. Finally, he will reach the top of the, once he finishes the block, he'll put a cap on top of it. So this each building block will be a beta tubulin dimer. So that will polymerization. So what happens is this Vinca alkaloids like vinblastine, vincristine, they will prevent the polymerization from the starting to happen. Like once it binds, that polymerization will not happen. So that prevents polymerization. Whereas eribulin, what it does, it will bind on top. That is, it will prevent the growth of the entire microtubule. But that microtubule will be shortened, but it will have a functional status. Whereas the microtubule, which is where the polymerization gets prevented by Vinca alkaloids, that will be non-functional. And on top of that, there is something called as GTP cap, where your GTP gets hydrolyzed into GDP, and there so there, that GTP cap, once you remove that cap, the normal procedure is that there is a GTP cap which helps in sealing the entire polymers together. So once we remove that cap, there is something that is a normal physiology which happens, that when that cap gets removed, it will goes into catastrophe. Once you remove the cap, imagine the entire blocks will fall down. So that is called disassembly or depolymerization. So that step is also a normal physiology which is required for the chromosomes to break apart to pull to the opposite end. That's what happens in anaphase. So that depolymerization is required for the cell to uh, separate out, segregate, and also for the cell to recycle the free beta tubulin which is left behind, and also for the cell to go into the next phase in the cell cycle. So that depolymerization is prevented by the taxanes. That is your docetaxel and your paclitaxel. So next slide, please. So the side effects will be leukopenia, thrombocytopenia, and sometimes first time you are giving could be some anaphylaxis in the form of sometimes acute shortness of breath or bronchospasm. And you don't need any dose adjustment in renal failure, but you will have to adjust doses in hepatic failure. Next slide, please. The next drug is called eribulin. This is also this eribulin is a non-taxane microtubule inhibitor. That it is it is a clear colorless aqueous solution. It's given intravenous, and you have to remember that this drug was also isolated from the sea. from again another sea sponge, and it was partly from a chemical which was halicodrin D. It is a semi-synthetic derivative of this chemical, and it is given intravenous, and 1 ml of, normally the vial which comes is 1 ml, and that 1 ml will have almost like uh, 1 mg per 2 ml. That is what the vial strength is. So per ml you will have 0.44 mg of eribulin, and the recommended dose is 1.4 mg per meter square day 1 and day 8 every 3 weeks. So it is an indicated is metastatic or unresectable liposarcoma, but in breast cancer also we can use. Next slide, please. So now this is what I had explained previously, where the main difference between eribulin, vinca alkaloid, and taxane. That is, eribulin will block your growth. That is the once that polymers are keep on piling on each other, then in between it will go and act, and it will prevent the further growth. But the whatever remaining microtubule will be functional, but that will over period of time that will also contract and become dysfunctional. But the microtubule which is formed because of vinca alkaloid is non-functional. Then taxanes will prevent that full depolymerization. When you are removing that GTP cap, that is a normal physiology which happens. As soon as you remove the cap, all the blocks which you have stacked together will fall down. That is a normal procedure. But this taxane will go bind to that GTP cap and will prevent that disassembly, due to which all the microtubules will be frozen. So that step is required for the for the chromosomes to be pulled to each opposite end, which happens in anaphase. So that step doesn't happen. Everything gets frozen at the center. Next slide, please. So this is just a gist of main thing to highlight the differences between eribulin, taxane, and vinca alkaloids. The same mechanism I've already explained, and also the side effects which you have to remember is for eribulin, the main side effect, or most of, because they are all acting at the microtubule inhibitor, their main side effects will be neuropathy. But QTC prolongation is most commonly seen with eribulin, whereas with taxane is normally the hypersensitivity reaction. But with vinca alkaloids is always the SIADH, which happens because of vincristine. Whereas the others, all this eribulin and taxanes and vinca alkaloid, they anyway will cause neuropathy, neutropenia, and alopecia. Next slide, please. So this adriamycin has already been previously discussed in previous breast sessions and other, because one of the main drugs. So I'll just give a brief synopsis of this drug. It was it's a anthracycline antibiotic which is isolated from the cultures of streptomyces. It was growing around a French castle, and then they found that there was something red color around the soil. It was some castle in France. Sometime one person was I mean, he suddenly noticed that around that area where this bacteria was this area was suddenly having a lot of reddish color and also didn't have anything growing around. And then they noticed that when they isolated, they found that this antibiotic component was there, which is the adriamycin. Adriamycin, as we all know, once you mix it in the bottle, it becomes red in color. So the red color is Adriatic Sea. There is it got its name as Adria or doxorubicin. Its main name is doxorubicin. So this is the trade name, Adriamycin. So that sea name was derived from the Adriatic Sea, which is the Red Sea, meaning Red Sea. So it inhibits the topoisomerase 2 to form, basically, it inhibits the nucleotide replication and also the DNA RNA polymerase integration. The main side, it comes in the form of powder. So you have to ensure that you give the drug, as a bolus over 10 to 20 minutes, because you don't, the main thing is you have to ensure that the IV line is secure, because you don't want to have any extravasation. So any extravasation which happens will be an emergency situation. And main side effects of adriamycin will be the cardiotoxicity, which are worried, which could be early as well as late. And the cumulative toxicity for cardiotoxicity would be your around 450 to 500 mg per meter square. So Now coming to the next drug, which is pasupenem, which is a multi-tyrosine kinase inhibitor, which it has a multiple kinase inhibition from VEGF receptor 1 to 3, PDGFR alpha, beta, and FGFR 1 to 3, CKID, LCK, and CMF. So it's given in oral form. Its dosage normally recommended is 800 mg OD on an empty stomach 1 hour before food or 2 hours after food. And the main side effects that, next slide, please. So this is the mechanism of action where you can see that at the receptor level, you have the VEGF receptor, and then the VEGF normally gets acted by bevacizumab. Normally, this drugs like sorafenib, sunitinib, pazopanib, they will prevent the autophosphorylation of the receptor, due to which it inhibits the signaling down, which in a way it acts on the prevents the angiogenesis, because some that most of the tumor cells they grow on neoangiogenesis, so it's blocking that step, which is the main step, and which is one of the hallmarks of cancer as well. So in a way it will reduce the cell proliferation, and also increase the apoptosis of those cells. Next slide. So the main side effects that when we counsel a patient before taking pasopanib is that we tell them to monitor their blood pressure, because suddenly they can have a rise in their blood pressure. So we need to tell them to first have a diary to at least weekly monitor their blood pressure to see that if there is no sudden rise in blood pressure, and then we educate them about the diet, like what type of diet, especially for patient is already hypertensive and patient is on antihypertensive medication. We ensure that they take a salt restriction diet, and as well as we tell them that to frequently visit a general physician or whoever is treating medical animals to titrate their dosage based on their BP readings. Second, that we are worried about is the proteinuria, which can happen in the urine. So based on the proteinuria, if you have a proteinuria which is more than we two like more than one, level one, grade one, then you would try to hold the drug till it resolves. So if it's a grade 2, grade 3 proteinuria where the protein levels are very high in the urine, then you would discontinue the drug. And it can also, there is a characteristic which happens is the hair, suddenly the hair becomes white for all the patients. So, and also you can have HFS and QTC prolongation. Sometimes patient might not tolerate and have very bad diarrhea as well. Next slide, please. The other drug which we have is tazimetostat, which is normally used in either metastatic epithelioid sarcoma or locally advanced, where you are not able to do a surgery, unresectable cases, or they have the ECH2 mutation. Then we can consider this drug, which is an inhibitor, which is a oral form. The strengths available are 200 mg, and the dosage is 800 mg BD. Next slide, please.
Sorry to interrupt, sir. 2 minutes left. Requesting you
Okay.
to summarize.
Okay. So the thing is that here the mechanism of action is that it targets the enhancer of the ZST homologue, where it is normally a epigenetic modifier. It prevents the addition of any methyl groups to the H3, the histone 3 at lysine 27. That is the H3. Any because of the methylization of these H3K7, their tumor suppressor genes are silenced. So what does ECH do is that it releases the silencing of these tumor suppressors. So once that silences are being removed, the tumor suppressor genes get reactivated, and that keeps the cancer, decreases the cancer cell proliferation. Next slide, please. This is the same thing. This is next slide. Side effects are mainly the bone marrow suppression, fatigue, and it can have risk of secondary malignancies like AML. Next slide, please. I'll be just rushing through these things because these are already been discussed previously. Sorafenib, which is again a multi-tyrosine kinase, which has a lot of KIT blockage, and it also VEGF inhibitor, PDGFR. It's been useful in a lot of these sarcomas, where especially for this dermatofibromatosis, in those cases we can give sorafenib. Sometimes some like multiple post lines of sarcomas also we can consider. Main thing we are worried about is the hypertension most of these TKIs will have the same adverse effects for which you have to counsel. Next slide, please. Next slide. The same thing is. So sunitinib is normally the sarcoma where we normally come across would be in GIST, that is gastrointestinal stromal tumor. It will come as a second line thing, or if a patient is progressing on imatinib, sometimes we can consider where it blocks the VEGF inhibitor and also KIT and FMS like FLT3 action. And also sunitinib dosage would be either you give it 50 mg. You can give it like 4 weeks or 4 weeks on, 2 weeks off, or you can give a 2 weeks on and 2 weeks off. So based on that, you can give a 50 mg or you can give a 37.5 mg.
Hi, Dr.
Next slide.
Ashvin. I'm so sorry to interrupt in between. We just have 5 more minutes to end the session, please.
Okay,
Yeah.
ma'am. Next slide, please. So the side effects are going to be the same for all the TKI, which will be mostly hypertension, skin rash, diarrhea, skin color changes, hair color changes. Then sometimes you can also have cardiotoxicity in the form of QTC prolongation, bad mucositis. Next slide, please. Cabozantinib, this drug is it's also a multi-kinase TKI, and it also inhibits. Mostly we use it for the MET. It has activity against MET and also VEGF inhibitor along with the AXL, and that commonly used in renal cell carcinoma. But in sarcomas also we are using, like especially in relapsed cases of osteosarcoma or in other sarcomas which are not like post pasopenib also we can consider giving cabozantinib. Next slide, please. Next slide. Okay, so I have come to the end of my session, and so ask questions. So ASK, so ask and shall be given to you, seek and you shall find, and case for knock and you shall. So you should ask. If you have anything, ask, seek and knock for the truth. If you don't ask, then nothing will be revealed to you. Thank you.
Thank you, Dr. Ashwin. That was very exhaustive, particularly the sections on methotrexate and the tyrosine kinase inhibitors. And you also explained very well about the differences between the drugs which act on the tubulins. So with that, I would like to invite Dr. Samir Rastogi, sir, to take this session forward. And the examinee is Dr. Piriya. Welcome, sir.
Hi, Dr. Abhishek. Thank you. Thanks a lot. So I'll start this. Can I have my PPT? So I will be doing this here. So, Dr. Priya, am I audible?
Yes, sir, you're audible.
So I'll just start with few questions. So this lady came to us almost 1 month back, and we started with vincristine, doxorubicin, cyclophosphamide. So first agent which was used was doxorubicin, and after doxorubicin infusion, she told us that she had redness. I mean, when she was admitted in the ward, and she told us that it was redness and swelling, and somehow a nurse didn't inform us. So what would you do right now?
Sir, she was presenting immediately or later, sir?
Immediately, she was admitted in the ward.
Okay, sir. Sir, it's like an extravasation.
Yeah.
So we have to leave the cannula in situ and aspirate
So
the.
sister didn't. Yeah, that's a nice thing. Sister didn't, and also somehow the patient, she compressed it.
Oh, she had to give. I mean, we have to give a cold compress.
Yeah, no, but I mean the patient manually compressed without cold.
Sir, we have we have the option of dextroxazone still if it is within 72 hours.
Yeah, can you see the image?
Sir,
how to go ahead with this? I can't see the image. First question. I mean, should I? Should I share this and do it myself? Is it possible?
Sir, we've shared the screen. You can say next whenever you want to move to the next slide, sir.
No, I want to
It's
share it
visible now.
myself. It would be
So
more
you
easy
sure,
for
sir,
me.
you can share it on your own, sir. We'll just stop the screen share. Over to
Please
you,
stop
sir.
it. Yeah. Yeah. So is it now? Can you see this?
Yes, sir. It's visible, sir.
Yeah, it's visible. And how do I make full screen?
So you can click on the button here, sir, on the extreme right.
Just to make it into
Yeah.
presentation mode.
Can't see that.
Sir, at the bottom right hand side, sir,
Bottom right, sir.
next to the minimize sign.
Mm.
So bottom
Yeah.
right.
So is that okay?
No, sir.
So, anyways, I don't know how to do this. You might share. That's okay.
Sir, if you can
So
click
would
on
you
the
share this?
slideshow on top, sir, next to animations.
Okay. Yeah. Slideshow. I did that.
Sir, from beginning, from current slide, any of the two.
Yeah. Is that okay?
Perfect, sir.
Yeah. So this is the lady. So Dr. Priya, what would you do?
Sir, cold compress 4 times per day,
Mhm.
and
Okay.
dimethyl sulfoxide application covering
So what
twice.
percentage? What percentage?
Sir, 90. I'm not sure.
99 is recommended is 99%,
Yes,
but
sir.
then 50% is available most of the times online or somewhere, but they are not readily available. What else? Now she is a Canadian resident and she was admitted with us and she was terribly conscious about her scar and everything. What else can you do? The resource, there is no resource constraint. Am I audible?
Good here, sir.
Can you hear me?
Yes, sir.
Yes,
you're
sir.
Sir,
Yeah. I don't know if she is able to this see.
I'm able to see, sir. This is okay, sir.
So okay. So how do you manage extravasation?
Sir,
So we did cold pack, we did dextrazoxane. So how do you give dextrazoxane IV?
IV in the opposite arm, sir.
Was it what is the dose?
Sir, day 1000, day 2000, and day 3 500.
Yeah. So we are just reinforcing this thing, and we gave dextrazoxane, and on very first day, and because it was being given as a cardioprotectant, we were using with doxorubicin, and it is at 48 hours. Somehow, with this massive extravasation, and she didn't have anything, and right now she is well. So anthracycline extravasation, cold compresses, I mean cold packs, and every few hours, see, hourly. DMSO is a tough thing. We have used DMSO. It might lead to skin reaction. So dextrazoxane would be the best thing. Uh, so what do you think? Like, how do you prescribe the high dose MTX? What
Sir,
all care
for
precautions do
high
you
dose,
take?
sir, for high dose MTX, the hydration and alkalization of urine is recommended, sir,
Mhm.
before starting the methotrexate. So on
Mhm.
day 1, we start with either oral soda bicarb 600 mg every 4 hours, and IV hydration 2 to 3 liters per meter square. And when the urine is alkalized, we start with the high dose methotrexate along with the IV and oral hydration, and
Mhm.
alkalization also. We keep checking the pH every 6 hours. And if infusion is stopped, we check the methotrexate levels, and concurrently we start on
So
glucosamine.
what should be the methotrexate level at 4 hours?
Sir, it should be um, we do at 24 hours.
No.
10.
What should be the methotrexate level at 4 hours? So you check it. I mean, 4 hours. It should be more than 1000. So the therapeutic is 1000 micromole per liter. And that's why in
Okay, sir.
osteosarcoma you want peak level, and in ALL you don't want peak level. So at 4 hours now it is not routinely done, because 12 gram per meter square majority of time it reaches that level. So when do
Okay.
you cap? So a person has body surface area of 2.3. What is the capping dose of high dose MTX?
It's 20, sir. 20.
Yeah, 20 grams. Someone has written 20 mg. Yeah. So also okay. So what is definition of high dose MTX?
Sir, it is more than 2 gram per meter square. Not sure.
Sorry? It's more than 500 mg per meter square. But in osteosarcoma,
Okay,
the therapeutic dose is 12 gram per meter square. Capping dose is 20.
sir.
You don't give less than 12 gram per meter square in osteosarcoma. It is non-therapeutic.
Okay,
So
sir.
what about gemcitabine docetaxel? What is the dose of gemcitabine docetaxel in leiomyosarcoma or any other sarcoma? Where would you like to give? And what is fixed drug rate? So anyone else, the
Sir,
dose of
gemcitabine is 1,000.
okay. So no problem. I mean, these questions were actually framed by so this gemcitabine, you can use 675 mg per meter square to 900 mg per meter square. And uh, fixed dose rate is when you give 10 mg per meter square per minute. The phosphorylation kinetics of gemcitabine are most favorable. And also it is able to maintain the level 10 micromole per liter. So therapeutic level of gemcitabine is considered to be 10 micromole per liter to 20 micromole per liter. And the sustained it is, the better. So in sarcomas, fixed dose rate is given. Though in pancreatic C, it was tried. In phase 2 trial, it succeeded. In phase 3 trial,
Okay.
it failed. And but in sarcomas, there is no
Okay, sir.
comparison with normal 30-minute gemcitabine. It is given as 10 mg per meter square per minute. So usually gemcitabine, unlike other diseases, in sarcoma, it is given over 90 minutes. Am I clear?
Okay, sir. Okay, sir.
So what are the risk factor of ifosfamide-induced encephalopathy?
So young females and
Sorry?
chloracetylene. I'm not sure about the risk factors, sir. I'm not sure about the risk factors, sir.
Okay. Anyone else? I mean, is it interactive? People interact? So one has said pre-existing renal dysfunction. That's right. Concurrent nephrotoxic agent. That's another thing. Dose is a bit doubtful. See, dose is there are studies in which dose and brain metastasis have not correlated with ifosfamide-induced encephalopathy. Low albumin is one. Then poor performance status is another. Use of apricap, because apricap is actually NK1 antagonist, but then it has inhibitory action of CYP3A4. Now CYP3A4 and CYP2B6 are important for this chloroacetaldehyde. So if it is ifosfamide is usually metabolized by CYP3A4. If it gets inhibited, then the level of chloroacetaldehyde will raise. So in that case, this pelvic tumor, I'm not sure. Yeah, age is okay. Concurrent cisplatin is okay. So yeah, age, nephrotoxicity, or already existing renal dysfunction, having nephrotoxic drug, and also low albumin. Now people try to supplement albumin also. There is a retrospective analysis in 2010 where they supplemented albumin, and they found that there was no difference in IFOS-induced encephalopathy, and in both arms, without or with, there was no difference. But somehow, still, a lot of institutions are practicing because there is no prospective data, and there cannot be randomized trials. So that's what. Yeah, the question was, I think,
How to
the
manage
question
is
is IFOS-induced
IV mechanism.
encephalopathy. Yeah.
Yes,
And
sir.
how
And
do you
it is,
manage
second question is how to
IFOS-induced?
manage, sir.
Yeah.
Sir, injection thiamine has been studied, sir, and injection methylene blue IV 50 milligram IV every 4th hourly.
I mean, it resembles Wernicke's encephalopathy very closely. So thiamine might be given, and
Yes, sir.
this, but the evidence is not very strong. It usually starts within 48 hours, so that's okay.
Okay,
So,
sir.
I mean, it. So, what about? Is there? How do you treat metastatic synovial sarcoma? After first line progress on doxorubicin and ifosfamide, how would you treat? And what is preferred regimen in synovial sarcoma?
Sir, T-cell therapy or
Any regimen? I mean,
I'm not.
this question was given to me, so I just passed on. But what is the preferred regimen in
Okay.
synovial sarcoma? Is it
Sir,
chemosensitive? You have
synovial
used
sarcoma is
ifosfamide.
sir, it's not chemosensitive.
Okay.
So
So
first
I'll
line you
just
are
see the
asking, sir, or second line?
any line. I mean, so any line.
First is like uh,
Is it ifos
IV with
sensitive? Is it doxo
Mesna, sir.
sensitive? Sorry. So it
It's
is a
not
chemosensitive
chemosensitive, sir.
sarcoma. Yeah. And this MAGE4 therapy, which is melanoma acid antigen, this is now approved for synovial sarcoma. So it is
Okay.
chemosensitive. IFOS, doxo both have excellent activity in synovial sarcoma. These are the agents: doxo, IFOS, pazopanib, gemcitabine, docetaxel has been tried, not very active. High dose ifosfamide is excellent. Now, what is high dose ifosfamide? Enlotinib is coming up, regorafenib, and why I'm discussing about synovial sarcoma? It is the most common soft tissue sarcoma in our population. Perhaps it is more than leiomyosarcoma, which is distinct from the West, where leiomyosarcoma is the most common. So this is one of our phase 2
High
study
doses.
in which, sorry. So gemcitabine docetaxel is modestly effective.
Ifosfamide, sir.
You're not audible. Am I audible?
Yes, sir, you're audible, sir. Nithiya, you're not audible to us.
Yes, sir.
So I
Ma'am,
don't know.
am I
For
audible
everyone,
now?
yeah, you are audible now. But gemcitabine docetaxel is a very modestly active chemotherapy in synovial sarcoma. This is the only phase 2 trial that is there. And the 3-month progression free rate was 45%. So, anyways, these are the agents in synovial sarcoma. You can see the high dose ifosfamide is the best drug with a response rate up to 44%, which is unprecedented. This is Gustave Rossi French data. 44% is unparalleled after doxo and ifos, but the toxicities were there in 5%. I mean, grade 3, grade 4 toxicity. So we have a study going on high dose ifosfamide, and Dr. Vineet, who is our student, is carrying this study. And this is like people respond very well. So far, there are a lot of good responses. This is partial responses lung. You can see these lung nodules. And this is another large foot synovial sarcoma with metastasis, and the metastasis decrease. So for synovial sarcoma, ifosfamide and doxorubicin are pretty active. Ifosfamide high dose has 44% response rate. Gemcitabine docetaxel has modest response rate. I will come to T cell therapy. Why T cell therapy is not relevant for us? So enlotinib has, I mean, there is a data about enlotinib, and it was randomized to dacarbazine. So far, paper hasn't come, but then at 12 months, 26% of people remain not progressive, which is quite contrast as compared to dacarbazine. It might be an active drug. Median PFS remains dismal because median PFS tells you when 50% of patients progress. It doesn't tell you if 25% will never progress for 1 year or 2 years. So we have tried enlotinib, we have tried regorafenib, and regorafenib is also has also good responses. Perhaps in a progressive synovial sarcoma, you might try enlotinib and regorafenib. Enlotinib is available free of cost right now, compassion basis program. What about adoptive T cell therapy? Anyone, why this is not relevant for us? I mean, it's absolutely irrelevant for our population. Yeah. So HLA-AO2 is not common. I have seen people prescribing that you should get enrolled in NYESO1, New York esophageal antigen 1, which is present in what all sarcomas have NYESO1 positive? Can someone tell me? What all sarcomas have NYESO1 positive now that they are on the verge of FDA approval, and one of them, MAGE4, has been FDA approved? So MP and ST, synovial sarcoma, are and myxoid liposarcoma, they are NYESO1 positive. So why this is not relevant? Because this is HLA restricted, and I mean, whatever 50% sustained response, they are found in HLA-AO2 restricted population, and this is the FDA approval for MAGE4 T cell therapy, and this is the map where HLA-AO2 is mapped as per the prevalence. You can see in our population, in Caucasian, it is found in almost 50% of people. However, in our population, it is hardly found. So far, whatever patients we got it done, it doesn't, HLA-AO2 has come negative. So, Dr. Priya, are you there?
Yes, sir.
You understand it that this is HLA restricted. HLA-AO2 is not present in our population. So perhaps T cell therapy is not beneficial to us. It is for Caucasians, which harbor 50% of HLA-AO2. Do you understand this?
Okay, sir.
Okay. What is the difference between anthracycline and trastuzumab cardiotoxicity?
Sir, in anthracycline, cardiotoxicity is mediated by reactive species, and it accumulates. In trastuzumab, it is anti-HER2 mechanism, where the HER2 mechanism protects the heart from normally. When trastuzumab is given, it blocks the HER2, and so the myocardiacyte get into damage.
So this oxidative stress or this free radical, this is outdated. What are the recent hypotheses for anthracycline-induced cardiotoxicity? I mean, this oxidative stress was, I mean, for a few years, it is not even consideration. What are the recent mechanisms for anthracycline-induced cardiotoxicity? Can someone type or... So, mitochondrial injury,
Okay.
ferroptosis. So these are the like the mechanism of action, and apart from free radical injury. So, and how does dextrose act?
Sir, it acts by chelating the.
Yeah,
I mean,
again, this is outdated thing that
yeah. Free radical means it acts by chelating, so it prevents formation of free radicals and thus protects. Then if it's mitochondrial injury, I'm not sure.
Okay. So how does anyone? Yeah, it causes inhibition of topoisomerase 2. That is the latest thing. And when topoisomerase 2 is inhibited, then the doxorubicin interaction with topoisomerase 2 doesn't happen, and thus leading to cardioprotection. That is the latest hypothesis. So yeah, so what is the dose of dextroxane? I mean, see, all the trials recently, even sarcoma, even osteosarcoma, whatever trials have come in last 5 years, they have taken dextroxane. So we must use whenever it is possible. This is an editorial by MD Anderson, Dr. Benjamin, where they recommend it from day one. And this is our protocol in AIMS. We are using in at least 20% to 10% people, we are using dextroxane routinely. What is the dose of dextroxane? I think a lot of people will know this. So 10:1, yeah. Sorry?
Ratio of 10:1 with that, yes.
Yeah, so we are giving it 10:1. And if we, since the vials are available in 500 mg, so we just round it off. So yeah, so preferred regimen in non-metastatic Ewing sarcoma. So what is I'll present a scenario. A 20-year-old, 15-year-old boy has come and he has when biopsy is done, femur Ewing sarcoma diaphysis, and 2D echo is normal, everything is normal, sperm banking done. What is the preferred regimen? How many cycles?
Sir, I mean, IE alternating every 2 weeks. Number of cycles is 9.
Can you tell me what is VAC, VAC, and IE? Would you use actinomycin D also?
Yes, sir. Vincristine, Adria, cyclophosphamide, and ifosfamide and etoposide, sir.
There is no actinomycin D, right?
No, sir.
Yeah, there is no actinomycin D. So during this protocol, there is no actinomycin D. In dose dense protocol, since 2012, actinomycin D is abandoned.
Okay.
And how many cycles would you give?
9 cycles, sir. Neoadjuvant.
9 cycles? No, total. I mean, okay, neoadjuvant, how many cycles do you give in dose dense? In neoadjuvant?
Every
It's not
2.
9 cycles. Anyone else? No, it's not 4 cycles nowadays. In dose dense neoadjuvant, no, it's not 3 cycles. It's 6 cycles. 6 cycles neoadjuvant. So yeah, 6 cycles you give neoadjuvant, and total of how many? Total of 14. This is dependent upon AEWS 0031, but in AEWS 1031 they use 17 cycles. So both 14 or 17, based upon this, can be given. The outcome of AEWS 1031, in which they compared with topotecan and cyclophosphamide, were better, but this is inter-trial comparison. So even if someone gives 17 cycles, that's fine. So what do you think is the outcome of Ewing sarcoma? I mean, just in non-metastatic, what is the outcome?
I'm not sure, sir.
Any 5-year disease-free survival?
Up to 75, sir. I'm not sure.
Overall survival and disease-free survival, DFS, in both, yes, 80% is quite high. It was 70% in second AWS 1031 and 60 something percent in AWS 031. So that's okay, around 70%. That's okay. What about trabectedine? As we discussed about trabectedine, how to administer trabectedine, what is the vomiting potential of trabectedine, in which all tumors trabectedine has been used, and can be used first line?
The second line, metastatic soft tissue sarcoma, sir.
Which sarcoma? Which sarcoma it is FDA approved? It is FDA approved for liposarcoma and leiomyosarcoma for metastatic. So someone has told myxoid liposarcoma in first line, Prajwal KP, and see, it cannot be used in adjuvant. So, but metastatic, you might use it. Yes, in metastatic, it might be used in first line. Data is very less to use in first line though. And pre-medication, how much dexamethasone, yeah, to prevent hepatotoxicity and allergy. And LMS4 trial was doxorubicin plus trabectedine with trabectedine maintenance. So any other recent trial in Ewing sarcoma that has shown that it can be used? Any other trial in Ewing sarcoma? And what are the doses have been used in different trials? We understand LMS4, it can be given with doxorubicin along with maintenance in leiomyosarcoma. It is FDA approved for second line therapy onwards for liposarcoma and leiomyosarcoma. Anything else? And what are the dose is 1.5 mg per meter square in FDA approved. What is the dose? What was the dose in LMS04. Yeah, so LMS04 has 1.1. And there is another trial that has come up, which is SARC-030. Yeah, so this is LMS4. Again, you have a survival benefit here and PFS benefit almost double, but a lot of toxicities. So this is a new trial which has phase 2 single arm trial, trabectedin 1 hour infusion. Again, in LMS4 it was 3 hour infusion. In this it is 1 hour infusion with irinotecan. Almost of 16 patients who were evaluated, 5 patients had partial response and 2 had stable disease. It is yet under recruitment, but this is perhaps promising. I mean, we are talking about sarcomas. So yeah, in sarcomas, Ewing sarcoma might be SARC 037. It might be used in Ewing sarcoma. But the problem is, since the paper is not published, we don't know if these people have received irinotecan or not, and what fraction of people who have already received irinotecan will benefit from this. So, any newer therapies in uterine leiomyosarcoma? What is tezemetostat? We have discussed it. So, newer therapies in leiomyosarcoma.
Sir, it is EZH2 inhibitor.
In uterine leiomyosarcoma, I mean, first thing first.
Uterine leiomyosarcoma. I'm not sure, sir. Newer
Anyone
therapies.
else? I mean, a person who has progressed on everything. What do you want to do? I mean, post trabectedin, post doxorubicin, post dacarbazine, or let's not say dacarbazine, post eribulin. Yeah, so PARP inhibitors, it's olaparib plus temozolomide. So
CDK.
pelbo is not the option. Immunotherapy TMB. See, uterine leiomyosarcoma, there's a paper of Suzanne George. She's from MSKCC. It came in 2018 or 19. They tried 12 patient immunotherapy, all failed. So this Himlata, I think this is immunotherapy is not an option for uterine leiomyosarcoma unless TMB is high. But that situation will only let up in 2%. Now pelbo plus this is not pelbo plus PARP. This is PARP plus temozolomide. So what do you think? I mean, can we give this temozolomide plus olaparib blindly, or we need to get this done the BRCNS, the HRR panel? So no problem. This is the first paper that showed that in 10% of uterine leiomyosarcomas of 60 patients, 6 had BRCA2. 10% will have BRCA2 mutation. Rest 10% will also have HRR genes, other HRR genes. And now that we have a study, look at the waterfall plot. Again, so promising, almost magical. After multiple lines, you give olaparib plus temozolomide, and there's so 27% response rate. So it's a beautiful waterfall plot. And this is one of our patient who take olaparib plus temozolomide, complete response after almost all lines. So this is a new therapy. You have a person with uterine leiomyosarcoma. You should expose them to PARP inhibitor. And even mutation is not required because whole exome sequencing is required, which is very difficult. So 27% in unselected population. What is tezemetostat?
Sir, it is a EZH2 inhibitor, sir.
So yeah. So
Yes.
what is this INI1 and what is this SMART CB1?
Used in epithelial.
Yeah. What all cancers have this INI deficiency? Anyone else? How many, like, what are the INI1 deficient tumors? Rhabdoid tumor, excellent. But that is in very small people. ATRT, excellent. And hepatoblastoma, I'm not certain of. INI deficient chordoma. INI deficient epithelioid, MPNST. And epithelioid angiosarcoma. Angiosarcoma. Epithelioid sarcoma we have, so they were epithelioid sarcoma we have listed. And so thus, once INI decreases the expression, the EZS2 increases. It's like seesaw. And if EZS2 increases, you need EZS2 inhibitor. Yeah, renal medullary carcinoma. Yeah. So, okay. So yeah. So this is the 15% response rate, and as you can see, the waterfall plot, even response rate is not indicative of all the response rate, because some might have 10%, 20% response rate. So this is one of our patient in which we started using tezimetostat, and patient had good response. So how does these EZS2 inhibitor or this act, what is the median time to response? What do you think is the median time to response in these therapy? It is 4 months. It has waxing and waning. Being epigenetic inhibitor, it's not a chemotherapy. So they might take their time. Okay. So what about immunotherapy in soft tissue sarcoma? I mean, what are the subtypes in which immunotherapy? Can I have all the subtypes in which ASPS? Okay. Let's write this ASPS, and what else? UPS with maybe PDL1 more than 1%.
Angiosarcoma
This is
second
the,
line setup.
sorry, with sarcoma? Which one? Angio.
Angiosarcoma.
Angiosarcoma, but there had to be angiosarcoma of scalp, which have UV ray signature and sun exposed area, right?
I see.
Not visceral angiosarcoma. And
Sir, I regret the interruption, sir. We have 10 more minutes to end the session.
I have learned in 5.
Yes, yes.
Thank you. So, and so myxofibrosarcoma, which is just a Kaposi sarcoma, both HIV related and non-HIV related. What else? Kapos UPS, we have told. LPS, only in 10%, it's not very effective. So these are the sarcomas in which immunotherapy might be effective. Now, this is UPS, that the largest study showed of 40 patients, almost 23% had partial response, which is amazing. Again, this is superb. UPS, and does anyone know that it has been tried in neoadjuvant setting on UPS also? And what is the, now it is been tried in neoadjuvant setting. This is LPS, very few response rates, but yes, there are response rates. The chapter is not closed. So this is ASPS, this is one of our patient. Again, we started, it was approved in 2023, I suppose, but then we were giving immunotherapy since long time, and this is the complete response. This girl is still in complete response. It's a cold tumor, PDL1 is low. So atezolizumab is now FDA approved with staggering 37% response rates. And you wait for response rate, you don't rush, they might come after 1 year. So we have patients on this ASPS on atezolizumab. This is UPS, good PDL1, and years on response. This is the latest this. That in neoadjuvant setting, in high grade UPS, you give this and it might be 50% TFS. So now it has come in adjuvant and neoadjuvant setting also. So I think rest has been discussed, and I'm ready for questions. I mean, we can unmute anyone if questions. Priya, you want to ask some question? Any sarcoma, anything that pathology or this?
No, sir.
Anyone else?
No, no, sir.
Fine. So, I mean, okay, I got a question. Regarding ES, after 9 or 12 weeks, we evaluate for surgery. Say we give six dose dance cycles. So now weeks is like if we give 6 doses in cycle, then we will it for surgery nowadays. Anything else?
So there's another question.
Can
So
we use yeah. So can we use dose dance earlier? Can uh, can we use dose dance earlier and in adjuvant setting 3 weekly? I don't know why would you like to do that. I mean, if the DFS is better in dose dance, you can use it. But 3 weekly, if person recurs, he might just tell you not to do this. I mean, can we use trabectedin in synovial sarcoma? Trabectedin can be used in synovial sarcoma. A fraction of them, the median PFS in a study was almost 6 months. Uh, but then, yeah, you can use it. So you can use, but the outcome is not great. But yes, it is a therapy. I mean, after high dose ifosfamide. So you are saying that dose dense 2 weekly tolerability is poor. Are you using actinomycin D amol? Amol Rathod, yeah. Because VC and IE option for spindle cell sarcoma. You need to characterize this. IFOS doxo gemdosi TKI. Which kind of spindle cell sarcoma? Has NGS been done? Is pathologist saying it is UPS? Is it CD? I mean, what kind of IHCs are there? And FEPI therapy, why did you use FEPI therapy? I mean, it was very avid. FDR of gemcitabine osteosarcoma. Already gemcitabine has response rate of less than 10%. There are hardly any prospective studies for gemcitabine osteosarcoma and the response rate is really poor. I don't know how it will benefit. Upfront operated rhabdomyosarcoma adjuvant therapy. Yeah, so this is, I think, one of our colleague Prabhat is there. So yeah, it is at least 10 or maybe 14 cycles of adjuvant chemotherapy, 10 to 14 cycles. But then you need to decide because it is quite toxic. You need to also decide about maintenance. Now that maintenance is there, so after 14 cycle, you might give maintenance also. In sarcoma, surgery is always preferred. Wherever is the location, surgery followed by radiation. There is no surgery versus radiation. You always operate in sarcoma. First thing is surgery, followed by radiation wherever possible. And we discuss every time wherever you can put radiation, you should always give radiation. If your surgeon is okay, prosthesis, necrosis is not the risk. Even if necrosis is 100%, because any local recurrence will have systemic recurrence. So in Ewing sarcoma, any local recurrence might be difficult to deal with because they are accompanied by systemic recurrence in 90% of time. Radiation therapy is extremely important in Ewing sarcoma. In a high dose is totally out in metastatic RMS. I don't know, and it doesn't work in metastatic RMS. Resection criteria for lung mets in osteosarcoma. So there is a paper by Stephen Bilek. It says that if it is less than 3, if it is limited to single lobe, then the outcome is good. There are no such criteria. I mean, the older thought that you can also resect up to 16, but then the outcome will not be that great. So if you have single lobe metastasis less than 3, the outcome, it is late relapse. If it is early relapse within 2 years, which is considered chemo insensitive, doesn't work well. If it is late relapse less than 3, then probably this. Myxofibroma versus angiosarcoma difference. So angiosarcoma is CD31 positive. It is factor 8 positive. It is myxofibrosarcoma is just a modified version of undifferentiated pleomorphic sarcoma. So yeah, angiosarcoma is very vascular. It's a vascular sarcoma. So it's a pathologist prerogative, but then CD30, CD34 and factor 8, all these things are positive angiosarcoma. Anything else? So I'll write 2 questions. We don't change to actinomycin D. Since 2012, actinomycin D use is stopped.
So we are reaching the time, sir.
Yeah, I'm okay. I mean, I was just
Yeah, I think these questions we can take via the email, so if it's okay.
yeah, sure.
Yeah, Abhishek sir, are you there?
Yeah. Hi.
Hi,
Thank
sir.
Thank you, Samir sir, for a very
Yeah,
exciting,
yeah.
very exciting presentation and very conducting this all the way through. I think everybody will agree that we all got to learn a lot. Sarcoma it's such a heterogeneous topic. You cannot pinpoint, like, cover the entire sarcoma under the one basket. So it was covered very well by you. And with that, I'll hand it over to Dr. Nihanty. Uh, Please excuse me. I think I'll be taking leave after this. I have some important work. So it was really nice to moderate this session. So Dr. Nihanty, can
Thank you, Dr. Abhishek. Thank you very much.
Thank you, sir.
Thank you, sir. Thank you, Samir sir, for such vast and very detailed explanation of everything. I think it was a very great learning session to all of us. Thank you so much, sir. Abhishek sir, thanks a ton for moderating the session so well.